Now I call upon Dr. Nikhil Pradhan from UK, who's going to speak on periprosthetic fractures, Vancouver B2 and B3.
Thank you, Chairman and friends. Thank you once again to the organizing committee of YROC for giving me this opportunity. So this is my experience over the last few years, I would say about 20 odd plus years of periprosthetic fractures. I shall restrict myself to B2 and B3. I shall show you some of our failures and how we think we've modified the way we treat them. A couple of pointers that 93% are minor falls. So it is not a major fall that causes a periprosthetic fracture. Both by the Mayo Clinic and through the Swedish registry, 70 to 94% of the implants are loose. So very much like my previous speaker said, please be careful. Most of them are B2s rather than B1s. And they tend to happen at about 7 to 8 years post a primary. Again, the Swedish registry is extremely important as it tells you there's a higher mortality after revision surgery for periprosthetic fractures as compared to revision for other causes. So remember, these are high mortality patients. Extremely important paper from Bhattacharya. I would recommend people to have a look at this paper. It says that there is a 11% mortality at 1 year compared to fracture neck of femurs, which is 16%. So very high mortality rate. And another interesting comment he's passed, which is nearly threefold increase in mortality in patients who sustained a type B periprosthetic fracture treated with open reduction internal fixation as compared to revision arthroplasty. So mortality and impact is quite important. Classification, as has been said to you before, and B2 and B3 is what I'm going to talk to you about. So in our institution, we tend to investigate some particular pointers. Most of these are elderly, so we'll rule out urinary tract infection. Quite common, we found that it was present. Look for inflammatory markers, as when you start getting queries about is the wound leaking, is it infected, it's worthwhile having a baseline. Check for DVT, as these are patients who are not mobilized, have been in traction for a little while. We see a lot of patients who come to us from nursing homes and they are unwitnessed falls. So please, if you require, take a CT scan of the head. And we always do a CT to see whether it's a B1, B2 or a B3. Some things that we realized as we've progressed in our quest for getting this right is that the physiological age is quite important. And what is the pre-operative mobility of these patients? Were they on a walker? What were they on? When that decides where you want to take them back to. What are their comorbidities? As we know that multiple comorbidities will lead to an increased mortality rate. And what is the healing potential of that bone or of that fracture? And that is an important factor which I'll come to later on. What is the bone stock you've got to deal with, and how many previous surgeries dictates on scar tissue, etc. Okay, so let's look at the B2. So B2 is a loose stem, we know that. And as said by the previous speaker, we're going to revise this, we know that. Now here the proximal quality of the bone is good. If we see an elderly patient who's been on a walking frame, etc., what we really want to do is get this patient quickly up and about. So we really won't waste our time trying to play around with these fractures. We won't go after the proximal cement. If it is a cemented stem, we will knock out the loose stem, reduce the fracture. Remember, the quality of bone is good here, so you can just re-cement into the existing stem, use a long stem, and the patient is up and about. If it is a young patient, your demands are higher. So those are the patients where we'll think, okay, we need to deal with this properly, we need to get the cement out, and if required, consider an ETO at this stage, get the cement out. And then, depending upon where is the fracture could be in multiple places, though it is a B2. The quality of bone is good. You could either go for a short, long stem, cemented, uncemented. Completely depends on what you are good with rather than a diktat on what you should use. B3, now these are the ones where the stem is loose, but you don't have good quality bone or the fracture is seriously comminuted. If it is a young patient, at this point, you want to reduce the fracture and remove all the cement. It's an open fracture in a way, not open, but it's comminuted, so it's quite easy. You don't need an ETO. Nature has done it for you when the fracture happens. So go in there, remove all the cement, and probably use a distally loaded stem here. if you want an interlocking stem if required, and go ahead with it. If we've got a patient who's elderly, who's got multiple comorbidities, who's got the healing potential of that bone is not going to be good, sometimes what we've realized, it's really not worthwhile wasting our time on these patients. You're much better off excising that bone and putting in a longer stem and getting this patient up and about as the mortality is pretty high. I'll come back quickly to our experiences here on 2 points about the B1. And I think my speaker previously highlighted this as well. Extremely difficult to say whether a cemented stem is loose or well fixed. A smooth polished stem, which is cemented and hence by design it is supposed to subside within the cement mantle, will be loose if the cement mantle is fractured. So have a good look at the CT scan, even if you think on an X-ray that this is a B1, because you might find that the cement mantle is fractured, and hence a CT is useful, and consider revision in this case. And the second one, which has really given us a lot of hard time, is this very short transverse fracture at the tip of the stem, where you're seeing cement that's gone distally into the canal of the distal part of the femur. And what you find is that there's really the healing potential of this is completely reduced. The endosteal healing is near absent because there's cement distally and there's an implant proximally. And then the trauma surgeon goes in, you strip off all the periosteum, you're putting this huge plate. So really you're looking at a patient and saying, is this really going to work? And I think that's where Bhattacharya comes from, saying that you've got a high risk of mortality because this tends to fail and you go into multiple surgery scenario. A few examples. Here's a B2 elderly patient and the bone quality is good. So you want to say, is it a B2? You've done a CT, you can see the fracture has gone all the way up. So it is a loose stem, you fix it, and an elderly patient, reduce it, long stem, up and about, quick operation, don't waste your time. Young patient, this was literally done by one of my colleagues. He was on his bicycle, 3 months later comes back having had a fall off his bike, quite a loose stem. You can go in there, reduce it, and use a cemented stem. That's what my colleague likes to use, and he's got a good outcome. So it depends on what kind of implant you want to use. That's different, really. What's important is decision-making and a good reduction. Now, is it a B1 or a B2? Yeah, that looks like it's a very well-fixed stem, and you've got a nice oblique fracture. You might as well fix it. And as my able colleague said previously, this was taken onto a fracture table, and when a little bit of traction was applied, the stem actually moved within that mantle. All right? He wasn't a revision surgeon, but luckily he did his best. He's put this in. As you can see, he struggled with the proximal femur. He split it in multiple places. He just about got away with it. Okay? So you've got to be careful of diagnosing. Now, if you look at the X-rays, and those red lines are showing you, there's a gap between those metal, and you've got to be careful when you see that. Is that something where the stem had sunk over the years, or is it something that's happened at the time of the fracture? So there are some telltale signs, but I would say get a CT and you'll know. So this is now going to B3, which is the complex periprosthetic fractures. This is a patient who one of my colleagues had a ZMR in, which had a fracture of the implant. He went in there and he treated it by removal, a cortical stud graft on the lateral side, and then he wired it all in. Unfortunately, over the years, I think the implant was a bit short to start with. It collapsed, and the lateral buttress cortical graft completely resorbed, and there was a fracture of the whole of the medial side. So I won't go into the details, showing you all the details, but what we found here, the easiest way for this patient who's had multiple revisions is to just go in there, use a tumor or a custom-made prosthesis, and really the patient is up and about extremely quickly. So be careful about what you're aiming for, as you can get good outcomes with these as well. So the B1, short transverse fracture, cement at the fracture site. This is the one I say be very careful with, for it looks this way and you think, that's an easy one. I can deal with that one, yeah? But what you've got is a little bit of what might be a stress fracture, looking at it now retrospectively. The edges of the bone are a bit sclerotic. Is this going on for a long time? Yeah? And you could look at the post-op and say, well, it's not been really reduced extremely well. You could have achieved a little bit more compression. As you can see, an attempt has been made for minimally invasive. An attempt has been made for putting some morphogenic potential bone graft in there. But that comes to me with the plate broken. Yeah? And hence I say these are the B1s which you need to be careful with. You're much better off dealing with these in the first place with a revision, and that's what I did to this patient. And yes, there was a bit of a gap, but luckily for me, it all healed up well, and that's the X-ray at about 3 years. So in summary, think about one operation, think about elderly patients, think that it's like a fracture neck of femur. 90% of the prostheses are loose in type B. Consider patient factors, and what is this patient expecting? Achieve immediate stability, mobilize as soon as possible. And the last one is crucial. You need a good anesthetic team, cell savers, kit on the shelf, and probably medical and HDU backup with a good surgical team. Thank you.
Thank you, Nikhil. And could both Chetan and you join us on the podium, please?